Enabling access to medical records is an interesting part of general practice and soon to be a contractual part. That may be slightly delayed, but we're still going to cover how we can do this within practice, how you can do that safely and effectively, both for the benefit of the practice and especially for the patient, and why this might make your time really worthwhile. And to help us understand that, I've got Dr. Amir Hannan, who's going to explain all this for us right now. So let's get on and take enhance your primary care and learning. Welcome, GP learners, and thank you for joining for this live stream where we're talking about enabling access to records safely, effectively, and basically how you can do it responsibly as well. And I'm really happy to be joined by Dr. Amir Hannan, who's going to tell us a little bit more about himself and what he does. And I know he's definitely been someone that has led the way when it comes to access to records for patients in particular. So tell us more about yourself, Dr. Hannan.
Well, thank you very much for inviting me today on your program. So I'm Dr. Amir Hannan. I'm a full-time general practitioner. As you can see, I'm in my clinic. I do 9 sessions in my GP surgery. So I'm a full-time GP. I'm also chair of West Pennine Local Medical Committee, chair of the Association of Greater Manchester Local Medical Committees, and also chair of the World Health Innovation Summit.
Wow, I thought I had a lot of hats, and yeah, you seem to be beating me on those. How do you have time to do all that and 9 sessions?
I think the main thing is I'm a full-time GP. This is where I work. This is my main job. The other things, I've got amazing teams of people that I work with, and it's just amazing. I mean, my practice is amazing. I'm sure we're going to talk a lot about how we've enabled this to happen. It's definitely not a one-man show.
Absolutely. So I know that obviously contractually practices are required to give access to their records to patients. Originally it was meant to happen fully switched on from December. It got pushed back till April this year, and we're hearing that it may be pushed back a little bit more, and seeing what that means. But obviously this is something that is going to happen at some point, and quite rightly so, because patients having access to their records clearly has benefits both from the practice perspective, but especially from the patient's perspective. But I know this is something you've been doing for quite a while. So I think hearing the lessons that you've learned and your experience of this, I think, would be really valuable for many of our colleagues out in general practice to understand how this can impact basically the job that we do. So can you tell us how you got started with it, if that's okay?
Yeah, so I qualified as a GP in 2000. So that's, 22 years ago now. And I remember 3 years in, my nurse asked for a patient of mine to come and see me to review their diabetes. I remember he was a chap in his late 40s, early 50s. His English wasn't great. He came in to see me in the clinic, and my opening question was a simple, "How's your diabetes going?" Now, his answer completely flummoxed me. I had no idea how to respond to him. And the question was, well, what's it that he said that had thrown me? And what he said is, "It's fine." Now, you might think, well, what's so difficult about understanding that? All my training as a medical student, as a junior doctor, as a GP registrar, by then I was a GP. I'd been a GP 3 years. All my training had not prepared me for the answer that he gave. And in case you're wondering why that's the case, it's because when I looked on the computer, what the computer was telling me was that his HbA1c was about 150 to 160. It was off the scale. I didn't even know that you could have HbA1cs as high as that. And those who are listening to this who are not medical or don't necessarily know what diabetes is, your HbA1c should be less than 42. If it's over 48 recurrently, then you've got diabetes. In our practice, if you're in the worst 5%, your HbA1c perhaps is around 60, 65. This person's was 150 or thereabouts. Not only that, but it had been like that for the last 5-6 years. And initially, when I looked at that, I thought, maybe my doctors and nurses are not very good and need retraining or need to go on some educational course like what eGP Learning are providing on how to manage diabetes. But actually, we are an outstanding practice. We are a training practice. We've got some fantastic doctors and nurses. And when you looked at his consultations, when you looked at his record, what you could see was that he'd been invited back every 3 months, been seen by various doctors and nurses who'd stepped up his medication, who'd added in 2nd line, 3rd line treatment, as you would expect. But what the computer was also telling me was that he had not ordered a single prescription in the last 9 months. In other words, he was coming in, chatting with the doctor or nurse, nodding, and then probably walking out with a prescription and binning it as he walked out. And as I would say, probably injecting mangoes into his bloodstream in the meantime to get his blood sugars to be as high as that. And the reason it flummoxed me was that whereas I and those people listening to this call are thinking that's terrible control of his diabetes, he just didn't get it. And the reason he didn't get it was because he was fine. And the reason he was fine was because he wasn't getting angina pains. He wasn't blind. He wasn't on dialysis. He hadn't developed gangrene in his foot and had a leg amputated. All the sort of the risks of poorly controlled diabetes. But of course, he was heading towards those things. And the question was, what do I need to do to help? At the time, I didn't have an answer. A year later, in 2004, I suddenly found out that there was a system that allowed patients for the first time to be able to view that GP electronic health record, to be able to go online and be able to see the consultations, look at the letters, look at the test results, order repeat prescriptions. And that was then the journey of discovery. And of course, whilst he was a very extreme example, I'm sure we all recognize lots of our patients who, for whatever reason, don't understand their care, don't know what's going on. We know that the average patient only remembers about 10% of what's being said in a consultation, or 3 bits of information. So although we might tell them all the things that might happen, they might remember, or they might be told, start this medication, take it 3 times a day after meals, and come back to see me in a month's time. That's already 4 bits of information. I work in an incredibly deprived neighborhood. My patients are dying 10 years younger than the national average. So if the average patient only remembers 3 bits of information, I've just given 4, then they're likely to remember less than that. And if anecdotally, if I was to say which of those 4 bits of information they might remember, they'll probably remember to come back in a month's time and forget to take the tablets. So it started to strike me that actually, if patients could read what I've written in the notes, then they don't have to try and remember it all. They don't have to try to, and of course, the other thing was knowing that they only remember 10% of it. When it goes wrong and they've got terrible control of their diabetes or whatever it might be, we then end up blaming them to say, why have you not done this? Why have you not taken your medications? Why have you not done what I've asked you to do? And now look, you've got all the complications as a result of that. That just doesn't make sense to me. Nelson Mandela's got this wonderful quote, education is the most powerful weapon which you can use to change the world. And as I started to let patients have access to their records back in 2004, and for me, it wasn't prospective access, it was the full access to the whole GP electronic health record. What I started to do was start to educate these patients. And, the best care plan, the best education really is going to be that conversation that you've had with your doctor or nurse, where you've looked at the whole situation from a holistic manner. You've come up with what you think the problem is. You've written down why you think that is. You've written down the instructions in terms of what to do next, what you're expecting, safety netting, when to come back. It's all there in the consultation. If you think about those people that are listening to this, if you think about the consultations that you've had today, imagine for a minute if the patient could just read what you've written down. And instead of you writing a document, yes, it is a medical legal document that is probably never going to be read again unless someone complains about it. But now start thinking that you're not writing to defend yourself in a course of law, but actually you're writing so that that person can read it as soon as they come off the phone. How incredibly empowering that would be for you as well as for the patient.
So I guess with that change and stuff, you mentioned there was a company that helped enable the access and stuff. Obviously, the tech challenges of trying to now enable patients to have access to records can be daunting at times. How did you overcome that perspective, not only from the patients, but also from the practice staff itself?
Well, first of all, so you've made a really good point there about the tech, and since we're a tech, you're a tech podcast, we ought to talk about the side of things. So I didn't produce any technology. I didn't produce an app. I didn't produce a website or anything like that. We talk about the Three Musketeers sometimes, and Dr. Brian Fisher, who's still a practicing GP, developed a company called PAIRS, Patient Access to Electronic Health Records. And it was his company that developed the software that allowed patients to be able to view that EMIS GP electronic health record for the first time. Three Musketeers. So there was a third doctor, and the third doctor that I want to shout out for is called Dr. Richard Fitton. He's retired now. He was a big thinker, and I think from the 1970s, 80s, he'd been talking about the fact that patients, if they can access their medical records, they'll be able to do a lot more for themselves, and they'll also be able to help us. So in some ways, he'd done a lot of the thinking around it. Dr. Brian Fisher had developed the software, and I was the GP in a GP practice thinking my patients could really benefit from this. And you can see why they brought different skills and abilities together. And in fact, over the last 20 years, we've stuck together and continued to share our experiences and knowledge. We would go out and present to audiences like this about our experiences. And there was one thing that was very, very interesting that came out of that. And that was that every time we went, wherever we went, there were people in the audience who would say, yes, but. And they would come out with examples where they were really worried about why they didn't want to give patients access to the records. And we found that really strange, the three of us. We thought, why is that? Why are we not so scared? Whereas they were. And these were genuine people. These are not people who were out to catch us out. They really wanted to learn, but they were scared. And it started to dawn on us that maybe the way we were practicing our medicine, the way we were writing in the notes, the way we were dealing with certain situations, the way we were writing in those notes was a way that facilitated and enabled patients to be able to view those medical records. And so it became very natural for us to do so. But that was quite different from what other people's experiences were. The consequence of that was that, so the consequence of that was we approached the GMC, who very kindly hosted a series of meetings, and we invited the great and the good from the Royal Colleges, from a lot of the major patient organisations such as Diabetes UK, National Asthma Campaign, Asthma UK rather, Atrial Fibrillation Alliance, and a variety of others, in fact 40 different groups. And we had a series of meetings where we talked about what patient access to records meant, what the process was, and talked about some of the sticky areas, and tried to talk about the legal areas. So we invited the Medical Defence Union and the Medical Protection Society, and of course the GMC was hosting the meetings. NHS England, well, at that time it was the National Programme for IT. Anyone and anybody that was interested in this area. And the consequence of those three meetings was we produced some guidance on the professional responsibilities upon us in order to support patient access to records. That document then needed to be reviewed and signed off. And so the National Programme for IT then invited the Royal College of GPs, the Royal College of Nurses, and the Royal College of Physicians to come together and produce the first definitive guidance. And what we did was we looked at various different scenarios, abnormal test results, what about mental health, what about where the areas were where people might be worried and scared, and talk about what the legal view on this was, what the medical view on this was, and also how we, as clinicians enabling patients access to records, how we dealt with it. That guidance is actually on the top of our homepage or on our website. It's still on the Royal College of GPs website, and in fact, as material afterwards, I'll share that document with you because I think people find that really useful and very interesting. That was back in 2010.
Yeah, so in the YouTube channel description and stuff, I've already linked to your page that takes people to the initial online access sign-in page, so people can already access that as it stands. I guess you started telling us about the patient that kind of kicked off this whole concept of you wanting to look at open access. Can you give us, I guess, an example where it's really benefited specifically patient care? The one that kind of always comes to mind for you in terms of, this is why I do it kind of thing.
I mean, I've got thousands and thousands of patients, even this morning, patients that I've seen today who've benefited from access to the medical records. But if I give you a simple example of what this means and why it's not just about being able to see what the doctor has written, because most people say, well, why would I want to read what the doctor's written, their musings, their opinions about things? They're the doctor, it's their notes. Why does it matter to me? Why should I be able to see that? And I'm going to give you an example of a real patient. He's actually one of our testimonials. And this was a chap who was probably in his 60s. He'd retired. He'd been drinking a lot. And as a consequence of that, he developed an arrhythmia and got rushed into hospital, had a pacemaker put in, and got discharged. And I was the on-call doctor, and his wife rang up to say, I'm really scared, Dr. Hannon. He's been drinking a lot. He's had this pacemaker put in. He's just been discharged. I don't know what to do. We're all a bit scared. Can you please come and see him? So I went out to visit him, and yes, he was fine. He was cardiovascular stable and everything else. But I sort of said to him, things about it's really important. He needs to stop drinking, and if he needs any further help. Now, one of the things that I did once we'd figured out how to give patients access to the records was I then told everybody that they should have access to their records unless there was a very good reason not to. So I would go around telling everyone that they need to do this, and he was another chap. And of course, for me, if I ever thought that this person might fall ill, particularly at a time when the surgery is closed, so in 5.5 hours time when the surgery closes, you're then fending for yourself. If I thought there was something in the record that might be useful for that person, then I'd encourage them to have access to the record. So that was new for me. Never thought anything about him afterwards, other than thinking that he's going to be quite a difficult person because he didn't go to the pub, he didn't have a drinking buddies, he was just bored at home and drinking all the time. And you can imagine changing that behavior can be very difficult. About 2 years later, I bumped into him and he said, Dr. Hannon, do you remember me? And I said, not really, no, why? And he said, well, you came out to me because I was really scared because I'd had this pacemaker put in. I said, yep. And you'd said to me I should have access to my records. And you said, yep. And you consented me for access to the records and you gave me some PIN numbers. And I go, well, yeah, that's exactly what I do. But I'm sorry, I don't remember you. It's a couple of years ago. And he goes, well, you went away and me and my wife were really quite perplexed by this because we weren't expecting you to tell us to go online, and we didn't have a computer or anything like that. But because you'd said to me I should go online, we both decided to look in the newspaper, and there was an IT course, and we decided to join this IT course at the library. And whilst I was at the library, my wife likes shopping. So she started to learn about Tesco.com and all those sorts of things. And I enjoy gardening. And I'm thinking, where's this conversation going? And he goes, well, I had this interest in growing exotic plants in the UK. So as I learned about how to get online, I went online, I found some website that shows how to look after exotic plants. My wife, on the other hand, had become a dab hand at ordering things online. And so she then ordered some exotic plants. And then having sort of ordered them, I then went into the garden and started to spend time looking after these and tending for these exotic plants. And as a result of that, I suddenly started to find that I wasn't drinking as much because I was spending more time with my plants. And in fact, his wife even said that our relationship was rekindled again because it wasn't much fun having someone sitting there drinking all the time. And so now he's got these beautiful plants in his garden. He's stopped drinking. His relationship with his wife has really improved. And it was all on the back of me just saying to him he ought to go online. And that's a beautiful little example of how we can open up people's minds to doing different things and get involved in different things. And that had come as a result of me just asking him to get access to his records.
Okay. So I guess with that, you did mention there were some challenges and also some situations where you probably wouldn't look at doing open access for patients. Could you tell us about some of those experiences that you've had?
So our process is an explicit consent process. There's a questionnaire, so everyone can have access to records unless there's good reasons not to. However, just because you have the right to access your medical records, I still have a responsibility as a data controller to make sure it's safe or not. And so I put everybody through a test. Everyone has to complete the records access and understanding safety checklist questionnaire, and it's a series of questions. There's about 8 questions on there that you have to complete. It takes about 2 minutes to do. And those questions are me identifying how the patient is going to deal with certain situations. So, for example, there's a question that says, you might see some information in your record that might come as a shock to you or cause you some distress. What would you do if you can't speak to your doctor or nurse immediately? And they've got a couple of choices they can make. Not look at the test results, but wait until you've seen the doctor. Panic and get worked up. Wait till the surgery opens the next working day. Contact 111, contact the out of hours, or go to A&E or something else. Now, the patient can choose whichever choices they want to make. And if someone says, well, I'd just wait till the next working day, well, that's quite a reasonable answer. But if someone says, actually, I'd panic and get worked up, then there's a warning there that that patient might be someone who might not be able to handle their information. And I need to explore that a little more. So what that does, it then triggers a conversation with that patient. And the kind of conversation I'll have with that patient is to say to them, yeah, do you know what? If I had a chest x-ray that showed a shadow on the lung and I looked at that, then I'd get really quite frightened and perturbed about it. So if I'm that sort of person, when's the worst time to look at your medical record? Now, patients sometimes find that difficult. I guess the audience will find that quite difficult. So, Friday? I said, no, not, Sunday? I said, no, not Sunday. Monday? No, not Monday. Saturday? No, Tuesday. And then they get to Friday, and I go, yes, Friday. What time on Friday? And they look at me and they go, 12 o'clock? I said, no. 2 o'clock? No. And then they'll go, 6:30. And I go, yes. And then they'll go, and I'll go, why is that? And they'll go, because if I read something on a Friday night at 6:30, then I'm going to have to wait all weekend whilst I'm worrying until I can get in touch with the GP surgery. And said, bingo. So if that's the worst time to look at your record, if you're an anxious sort of person, then when's the best time to look at your record? And they might say 9 o'clock on a Monday morning, and I'll say no. And then they'll go 8 o'clock in the morning, and I'll say no. And they'll look at me strangely. And then they'll say 7 o'clock in the morning or 7:30, and I'll go, yes. And they'll go, why? And I'll say, because then when you look at your record and you realize you've read something that's upsetting you, you will then be on the phone at 8 in the morning trying to get an appointment. And I'd much rather you do that. And it's that simple little explanation. Sometimes it's not a technological solution we're looking for. It's not an artificial intelligence. It's just human intelligence. And as soon as a patient like that realizes that, oh yeah, if I look at my record before surgery opens, at least I know I can get in touch with the surgery or explain to them what I'm worried about something, so the doctor might be able to get back to me. So there's a series of questions that get asked. And as a consequence of that, if they've answered all the questions and it all looks okay, and the vast majority of patients answer them in a very reasonable way, i.e., I would contact the surgery the next working day, then at least that indicates that they're probably going to be okay. We then look through the record and check if there's anything in there why this person should not have access to the medical records. I'll come back to that in a moment. And then if there isn't, then we send them a message to say, congratulations, you've got access to your records, and also provide support in terms of what that means and where they need to turn to. Now then, that in itself indicates where there's a problem. So if somebody cannot give consent, i.e. they've got dementia, then by definition, they can't complete the questionnaire. Therefore, they can't get access to their medical records. That's understandable. So let's not wait until someone gets dementia and then start thinking about they should have access to their records. The second one is those with severe mental illness. So we're talking about paranoid schizophrenia. We're talking about personality disorder, those who are under secondary care mental health. With that group, they can still complete the questionnaire like anyone else would. But what I would then do is write to the consultant and say, this person has asked for access to their records. Is there any reason why you think I should not give them access to the records? So I'm not abrogating my responsibility. I'm not turning around saying that consultant's now got to decide. But what I am doing is recognizing that they're part of the team. And there may be good reason why they might suggest not to. Now, I'm going to give you a real life example of where that happened. I was in the middle of surgery, a bit like now. It was a Friday. And then suddenly my receptionist came running up to me about 11 o'clock. He said, Dr. Hannon, we've got a problem. I said, what is it? I said, we've got a patient who's rang the surgery now 20 times, and she's demanding she wants access to her medical records. I don't know what to say to her. Now, this was a lady who had had multiple admissions into hospital. She'd been sectioned on multiple occasions. And on this occasion, on this Friday morning, she'd just come off a section. And as a result of that, she then decided to take early discharge against medical advice, which she was able to do. And as soon as she came out of the hospital, she rang the surgery and was demanding access to her medical records and wanting her PIN numbers and everything else. Now, I said, that's fine, I'll deal with it. I rang the patient up, I asked her to come down. I said to her, look, you know I want everyone to have access to records. Unfortunately, she knew that. So she, even though she was in a state, she recognized that. And I said, and I went through the questionnaire with her and she answered all the questions correctly. I said, look, you've answered everything right. I want to give you access to your records, but I have this one rule that says that if you've been under secondary care mental health or you're under their care, then I need to ring and speak to your consultant. But I'm on your side. I want you to have access to your records. I will ring them up. I will contact them. I'll speak to them. I'll do what I can. And if they say it's fine, then I'll go ahead and do it. And by the way, the reason for that is because able-minded people might read something in a certain way, but if you've got mental health problems, you might read something in a different way, and it could affect your mental state. And so that's why I feel it's important that the mental health team should be aware of the fact they've got access to the records. I rang the consultant up. The consultant called me back, and he said, I don't want you to give him access to the records. And the reason for that is because he's finally met the criteria for personality disorder. It's a very, very big diagnosis. It's a diagnosis that has huge implications for patients. And I would rather call them back into outpatients in a few weeks' time, explain to them the diagnosis and how we've made it, along with the NICE criteria that we followed. And we've provided that support for them to be able to deal with that diagnosis. And for that reason, I would rather that you don't give them the access to the records. Once we've done that, I'll write back to you and confirm that you've got the access, and then we'll take it from there. And in fact, that's it. So I then rang the patient up, told them that. They understood why I was not giving them access at that point there. They went into the hospital. They had the appointment a few weeks later. They did find the diagnosis very distressing and very upset about it. But the consultant then wrote to me and said, I'm now happy for you to let the patient have access to the records. The patient will continue to self-harm and display all the, the symptoms of personality disorder. But then I called the patient in and I said, the consultant has given me permission. I'm now switching it on. And in that particular case, I didn't do it over the telephone. I didn't email them. I called them into the office. So they sat with me. I turned the screen around. I have my screen turned around anyway because I want patients to see what I'm doing. But I showed them the record so they could see personality disorder. I didn't go through everything with them because that wouldn't be appropriate. I trusted them enough, but I gave them the access and I said to them, if you do see anything distressing, that was the other thing. I called them in the morning, knowing that if they did see something, then they could call me back in the afternoon. I didn't leave it to them so that they'd then be worrying in the nighttime. The patient went home happy. They're still personality disordered. They're still self-harming and all the things that they're doing, but they never called me back. In fact, I can't even remember that patient now, and that was a number of years ago. They've got access to their records, but they've still got it. So it can be done, but it's in a controlled manner. The other one that I want to talk about is around safeguarding. And this was, another scenario, a real life scenario. And what happened is the surgery got a phone call from a student physio who'd seen a patient that morning. And the patient had disclosed to them that their partner had been abusing them. They'd completely taken over their life. They controlled everything, including the fact that they had told their partner to get access to their medical records so that they could see exactly what the doctor and the nurse had been writing about them. So this is your worst case scenario. This is the one that I'm pretty sure every GP listening to this will be thinking, there you are, there's the example. So I'm just going to say it. We've had that in the practice. We've experienced it. He had very, very severe COPD, so he was completely dependent on his partner. Not only that, but he'd written into the surgery and said, if my partner rings, please tell them everything about me. So as far as we were concerned, we didn't know that he was in a coercive relationship and that his partner had told him to do that so that she would then know everything about him. The consequence of which was we were happy to tell him everything that was going on, but it then meant that the GP practice was no longer a safe haven for him, because he could never say anything about his wife, it's his partner, because she'd get to know about it. And so you can completely understand what a complete nightmare. And this had been going on for a number of years, and we had no idea about it until he ended up going to see this student physiotherapist. And on that occasion, his partner was not with him. And so he was able to disclose the fact that his partner was controlling his life, controlling everything about him, and that she even had access to the medical records, which, by the way, this student physio didn't really know what she was talking about because it's not well known. Again, this was a number of years ago. And so the student physio rang the surgery and explained this situation. Well, the staff obviously freaked out, and they immediately came to me and said, Dr. Hanna, we've got this problem. So this is the important thing here. We are the data controllers. Yes, patients might have a right to have access to their records, but they also have a right to complain if they want to. So as far as I'm concerned, there was no question about it. As soon as you have a situation like that, as soon as it comes to your attention, it's part of our protocol. I immediately went onto the computer and I switched off the full access. Now, of course, reality is if that happens, the partner who then tries to log into the record and finds she can't do it is then starting to wonder what's going on. Has there been a glitch with the system or anything like that? And then when she's told, actually, we've switched this off, that's okay. She can put a complaint in. That's not a problem because we have a complaints procedure. And in that complaints procedure, I would then have to defend my action and I'd explain what I've done. And if she then wants to go off to the MDU, MPS, or whoever it is, but the point is that patient safety trumps everything. And so we did that. We talked about it in the practice. We talked about it with the staff, and we talked really about the fact that safeguarding is incredibly important. Now, this is the important point for anyone listening to this. Instead of thinking, well, there you are, because safeguarding issues can arise, we should not give patients access to their records. This is the important point. Access to the records did not put that patient into a dangerous situation. It wasn't the access to the records that was causing her to be in, or him to be in a dangerous relationship. It was the fact that she was in a dangerous relationship and needed to be safeguarded, whether she has access to her records or not. The important thing was to safeguard her, him rather, it was a him. We switched off the access. And then, of course, we activated the safeguarding policy.
So if I can ask a bit more into the safeguarding part of it, I know the anxiety many practices in particular have about the switching on the open access is the risk of, like you say, situations like that, people being able to share information that may not be appropriate for other people to see, partners, parents, for example. I guess particularly children, there's obviously stuff like MARAC reports, really confidential stuff that actually there's lots of third-party data. There's lots of work, let's be honest, that comes with making that data safe. And a lot of people have anxieties about how that's going to impact the practice, how that's going to impact how they do things. How would you answer those questions about particularly that starting that process? Because obviously this is a process you've been doing for many years. It's ingrained within the culture of the practice. For someone starting to do that, the potential of that workload is terrifying, I would imagine, for many people.
Okay, so I'll tell you my take on safeguarding, and it's kind of different to how it's defined. If you think about the patients who die of asthma, every year 2,000 people die of asthma, and when you look at the confidential inquiry, they don't die because they didn't get to see the professor of respiratory medicine. They die because they weren't taking their inhalers. They die because they didn't have their medication review with the nurse, their inhaler technique. They missed appointments. And remember that patients will only remember 10% what they remember, which is why, for me, safeguarding is really not about this small group of people who are in abusive relationships or whatever. For me, it's about the great unwashed. It's all the people with asthma, diabetes, eczema, depression and anxiety. It may come as a surprise to you, but I don't have access to my own medical records because my GP surgery doesn't offer it. And I sit there, this is crazy, because as a GP, I'm expected to look after my 13,000 patients that I've got in the practice along with my partners, but I'm not allowed to look after my own self. I've got to then go and see my GP and book an appointment to see them and all the rest of it. So when I'm thinking about safeguarding, I'm thinking about, well, what about the vast majority of people out there whose long-term conditions could well worsen? It's not just about long-term conditions. It's also about those with acute medical problems that might suddenly present themselves, and it might be a patient, as an example, a patient that I saw today who's been admitted into hospital. The first thing the casualty doctors are going to be asking, what's wrong with you? Where are you up to? Imagine if they could then show all the information that's in their record and what's been going on, so that they can understand what extra support they might be had. So when I'm thinking about safeguarding, I'm actually thinking about the great unwashed. I'm thinking about all those other people who could benefit themselves. However, there is this small group of people, and one of the games that I played, or I sometimes play with my reception staff, and I did this when I first started, when I began to realize that it doesn't require the doctor to check every single thing in the records and things, and some of these things can be done by our other staff. I went to my reception staff and asked them a question. I said, listen, if you were not going to give somebody access to your record, and they didn't know what the rules were, I was just asking them purely as receptionists, can you think of certain patients that you would not give access to? And they immediately gave me a name of a patient who had paranoid schizophrenia and had had multiple attempts at self-harm. And it was really obvious that that would be the kind of person who was very chaotic, had a drug and alcohol problem as well. And I agreed. And I asked them, why would you not give that person access to the records? And they were able to verbalize, well, they're chaotic, they've got mental health problems, they're not going to be able to understand these things, they might fly off the handle. And I said, well done. So although they didn't know the reason was because they're under secondary mental health. The second person they came up with really well was a person with alcohol and drug problems. So I said to them, I said, okay, they've got an alcohol and drug problem. Why does that preclude them from having access to the records? And as they started to think about it, they said, well, it doesn't really, does it, Dr. Hannon? I said, no, because as long as they can give consent, as long as they understand what they're doing, then just because they've got an alcohol or drug problem, it won't be an issue. And then I said, right, give me and it became a bit of a game, and said, give me another name, give me another name, give me another name. And would look through the record, and I'd look at the problems list, and then I slowly started to show them, and they got it very, very quickly. Now, if we take that, if you take, for instance, I don't know, let's go for an easy one. Let's go for a 5-year-old child who's had, their vaccinations, they've had a baby check done, perhaps they've had a couple of coughs and colds, perhaps they've had a couple, a viral rash or whatever. There's nothing in that record that would, cause any concern whatsoever. So you'd sit there and think, if the parent wants to access that medical records and they've done the questionnaire and they've demonstrated that they're capable of looking at personal information, why can we not allow them to have access to their records? Same sort of thing. Let's now go to a 20-year-old male who perhaps has asthma, but nothing else. He's been seeing the nurse very regularly. Perhaps he started smoking. He's been given some advice to stop smoking. The nurse has gone through the inhaler technique and given him some advice about how to take his inhalers and check the peak flows and what normal and everything else is. I'm sure everyone listening on the call here would say, yeah, why can't they have access to their records? And actually, let's not talk about prospective access. For me, I want to build trusting relationships with the patient. How do I build those trusting relationships? If I'm going to share everything with them, they're going to feel that they're trusted. If I've only shared them with only a part of that record, even if it's from today onwards, the first thing they're going to sit there and think about is, well, I can see the information from today onwards, but what about last week, last month? And that creates some sort of risk, some sort of distrust. Is they don't trust me with that information, right? You're starting from a low position. And remember, because of GDPR and because of the fact that patients are allowed to have access to records anyway, they can always put a SARS in and they can see that information. So really, why are we trying to prevent people from accessing? So they're okay. What about the 22-year-old who perhaps is getting contraception? Well, again, we can have a chat with the patient. We can look at the record. It's possibly not an issue. Very, very early on, when I first started giving patients access to records, I remember really well so this is back in 2004-5. That's 2 years before Steve Jobs had launched the iPhone. I remember an 82-year-old lady coming in, and she wanted access to a record. She'd complete the questionnaire. I looked through the record, and everything looked fine and dandy, until there was this one little recording that said that she'd had a termination of her pregnancy when she was about 17 or 18 years of age. Now, imagine now, she's 80. This is in 2004. So that would have been 60 years ago. That would have been in the 1940s. So that's the one that I called in, and I said, it's really good that you've got access to your records. I'm really pleased about it. I just want to ask you one question. She said, what's that? And said, how exactly are you going to go online? Oh, well, I've got this wonderful grandson, and he's a real whiz on computers, and he knows everything. I said, right, okay. I'm just going to show you something in your record just to check with you. Can you remember that you'd had a termination when you were 18? Now, at that point there, she went white as a sheet, metaphorically speaking. And she said, oh, I'd completely forgotten, Dr. Hannon. And I said, right, what had you forgotten? Tell me more. And she goes, well, I had this relationship, found out I was pregnant. And of course, at that time, my parents sent me off to Wales for a year to stay with my uncle. And I stayed there until I had the baby. Baby was then given to someone else. And then I came back. And then soon after that, they got me married. I met my husband. We had a lovely marriage together. I had 3 children. I'm now a grandmother, and I've got 20 grandchildren or whatever it is, including him. But nobody knows about that. And I thought, right, well, that's why I thought I better call you in, because that means that you cannot use your grandson to help you to get online. So I'm going to show you how to do that, or you're going to go on an IT course or whatever it is. But either you explain this to your family all these years later, or you let bygones be bygones, leave that alone because no one ever knew about that. You've built this whole new life around you. That doesn't matter anymore, and you let go. Now, that is an example of sixth sense that we need to apply, because in today's world, where I'm not saying terminations are normal, but it's a bit more acceptable. When I talk about that, and again, anyone who's thinking about doing these things needs to talk to their patients, their own population, what kind of population you're dealing with. If you've got a very predominant Asian population and they're all very religious and things, and you come across a child who does have a termination of pregnancy out of wedlock, you need to think through what the consequences of that might be. If other people found out about it, you might need to talk to that person. So there are things like that, and that's really why I've always said that the GP practice is the best place, because they know their patient population. And in the world where why can't we just switch on the access and just flick the switch centrally, that does not make sense. I know it's been happening, but as more and more people start looking at their records, all sorts of problems may arise, including harmful data and third-party data that they might see.
So in terms of trying to manage that aspect of third-party data, harmful data, I guess there's a couple of examples that come up. So obvious ones are, safeguarding MARAC forms that contain lots of potentially really damaging information in terms of memories for the patients, for the experience, or stuff they're not even aware of, obviously, when it's relating to the children. I guess other things, sometimes we have historic psychiatry notes that particularly state, do not share this with the patient, for example. Now, obviously, moving forward, we would hope that those kind of things are aware that these could be shared. But obviously, we're talking about potentially documents that were 10, 15 years ago in the past where this wasn't, as you said, something people were aware of. How do you manage those particular situations with patients and things?
Okay, so from the outset, what I'm going to say to you is that I talked about dementia, I talked about severe mental illness, and the third group that I'm very wary of is anyone under child protection or under safeguarding. Because of the potential risks. And really, I'm very into collaborative working. I'm very into let's share the problem rather than me take it on completely on my own shoulders. And so we really do need the safeguarding teams out there to engage with this, engage with us as data controllers and start to work through how we do that. But notice how my point about safeguarding is it's the vast majority of people with long-term conditions and things who we need to, sorry, my don't know if my screen just suddenly went blank there. I've just put it back again. That we need to think about. With regards to those letters. So when I come across a letter that's come from safeguarding, the first thing I'm looking for is who's been copied into those letters. Now, interestingly, and this is again part of the culture of how people work, even the safeguarding teams really want to work with the parents and families. So when you look at those letters very carefully, you'll notice that the vast majority of them have CC parents in. In other words, whatever is in that letter has already been shared with the patient, so it's not a problem. You can share it. However, you can well imagine that there may be some letters where it clearly states that you cannot share this information with the patient because it's not, they've not been CC'd in. When I started, back in 2004, we didn't have redaction software that could hide those letters. We now do have that on both EMIS and System 1, so that you can take an individual letter and hide it so the patient can't view it. Having said that, just as an aside, remember that when the patient comes into the surgery, then that redaction software is not there. So if you've got the screen turned around, then they will be able to see the things that you've hidden from them. So you need to be wary of that. And at the moment, we don't have a toggle on the system. We should do. So anyone's listening there's a TOC solution. There should be a button that allows us to hide third-party data if the patient is in the room with us. Really simple solution. Why have they not done that? But what I really want to talk about is how I actually deal with third-party data. And again, I've done this from, probably about 10, 12 years ago when I came across it. So if you, for instance, came to me and said to me, Dr. Hannan, you're going to be seeing my wife later today. I'm really worried about her because she's been drinking a lot. So you're providing me with third-party data about your wife. I, as a GP, have got three options. The first option is that I'm going to try to remember that, not write anything down in the notes, but try and remember it so that when I see your wife later on this afternoon, I kind of bring it up, even though it's not in the records. Now, you're frowning, and I'm frowning as well. And in fact, if there's anyone from the MDU or the MPS, then I'll tell you very clearly, that will not be defendable if you have not written that in the notes. It's important. You must write in the notes. So the message out there is, no matter what you think about records access and whether you agree or disagree with it, as far as your record keeping is concerned, you must write in the notes. Otherwise, you will get yourself into a lot of trouble. So although that's an option, it's not really an option. It's a non-option. The second option is that there is an accusation that this wife has been drinking. It may not be clear, because if she's been drinking in pubs and clubs and things, then it could be anyone that's made that. If, on the other hand, she's been drinking at home and the accusation comes, then clearly it's got to be someone in the house that's made that accusation. That's likely to be the husband. But the second option is there is an accusation. And the third option is husband says that wife has been drinking a lot. Now, what I do is whenever that third party provides that information to me, so if it was you telling me about your wife, I tell them those three options. Now, you might say, I just want you to try and remember it, in which case I turn around and say, well, I'm sorry, I can't do that. That goes against my professional standards and ethics, and I'd be shot to pieces and probably refer to the GMC if that happened. So it's trying to explain to them that although they might think it's an option, it's a non-option, in which case it's one or the other. Now, of those, and it hasn't come off very often, it might be about 10 or 15 times perhaps in the last 10 years where that situation has arisen, I would say that 9 times out of 10, guess what the patient has chosen? If it was you about your wife, what would you want? Dr. Gandalf.
Husband says?
Yes. They say, write down in the notes the name, put my name down, husband says. And that's been really interesting because people wouldn't expect that. They'd expect just an accusation. But that's because the likelihood is that if you've got to that point there where you're having to ring the doctor up, you've probably had it out with your wife. And you said to her, listen, if you don't stop drinking, then I am going to tell the doctor. And if they still say, well, go ahead and do it. So you then ring up and you're then saying, I want you to know, and write it down. I think the other thing also is that they want to do everything they can to show that they really care, because that's the reason why. Otherwise, why would you bother ringing up? You've got better things to do. So husband says, and they're doing that knowing that if that person has got access to their medical records, and say if, because even if they haven't now, do you know what? The world is moving that way. Whatever you're writing in the notes now, at some point in the future, people are going to be reading those records. We might as well think about it now. That person will see, and they'll see that their husband cared so much that they'd even written in the notes tell them that I've done it, even if it means that that relationship then breaks down at that point onwards. The important point about this is that that third-party data, if that third party is telling me this, then we should not treat it as dangerous and say we should redact it or all that kind of stuff, but rather ask that individual, how do you want me to deal with it? Give them the sense of control so that they then know that I've written that in the notes. That's a much more adult way of doing it. And I call this really the partnership of trust, this relationship that exists between the patient, the clinician, the carer, and the electronic health record. And we're trying to build trust. And what better way of doing that than actually saying to that third party, this is what I'm going to do. The same is true for harmful data as well, that if you know it's harmful data, talk to that person, think about it. When it comes to the patients, one of the most difficult things for me before I switched on the access, the hardest thing that I have to do is break bad news. Tell somebody, I'm really sorry, but there's a chest x-ray that I've done. It shows a shadow on the lung. It's possibly cancer. I'm going to refer you on a 2-week wait. But you know what's even harder than that? What's even harder than that is delivering it late. And the number of times before I started enabling patients access to records where I'd see an X-ray with a shadow on the lung, and I'd ring up the person's number at home, and the partner would answer the phone, and then I'd say, "Oh, where's your partner?" And they go, "They've gone to work, or they're not here." But it's okay, Dr. Hannon. We've got no secrets, and I know that they went for a chest X-ray. Is everything all right? And of course, you're dancing around. You say, "No, it's all right. When do you think they're going to be back? When can I speak to them?" and things. It was a very difficult conversation. Now, when I'm referring somebody for a chest x-ray, when I'm doing a blood test, when I'm arranging an ultrasound scan, when I'm referring the person to the hospital, at that point there, I'm saying, I want you to have access to your records. In fact, when they're having the chest x-ray done, I'm saying to them, can you actually go online and check for yourself when the chest x-ray is going to come, because it might take 2 or 3 weeks to come back. Look at the results, and then once you've done that, then book an appointment with me. But remember, I've done that with somebody who's already completed the questionnaire that says how they're going to deal with if they saw some bad news. If I am going to send them a chest x-ray and there's a possibility that there might be cancer, I might also have that conversation with them to say, listen, I'm not sure about this. It's an opinion, but I'm just checking that this isn't, cancer or whatever it might be. So I kind of warn them. In the same way as if I'm going to do a blood test, I warn them that I'm checking for diabetes, so that they can decide whether they want to look at that result themselves or whether they prefer to actually ring the surgery and speak to the doctor. So again, let's do a bit of shared decision making and say to them, I'm trusting you to see that information. If you see it, you need to think about how you're going to deal with it. But your other choice is to come back. The third thing to remember is that if the patient can see that test result before I do, then if it is abnormal, then they might well ring up the out of hours or casualty or whatever. It might save a life. So from where I'm sitting, I actually think that the more we can be, I call it responsibly sharing the information. It's not a free-for-all. It's not transparency. It's responsibly sharing the information with the patient, knowing that there are potential risks, but there are huge benefits to be had.
So if I could pick up on some of those aspects as well, if I could. So you talked earlier about the way that you write records. Obviously, when you're sharing records, it may be that you do write the records in a different way. I know in some organizations, they teach you actually when you write in the records, today we discussed your health issues. We advise that you do this, talking more, I've forgotten which party of language or terms that is, unfortunately, but rather than the classic reporting what happened in the consultation, which most people are taught in medical school and general practice training and stuff. Is that something you subscribe to? Is it a different type of way that you document specifically the notes and things, so that because you are aware that obviously majority of patients will see them?
Yeah. So to just give you some idea, every single patient I dealt with today, yesterday, Monday, every single patient had full access to medical. Actually, no, there were 2 or 3 people yesterday who didn't have access to their records, and I signed them up in the consultation. And by the way, just on that, the consulting room is the most powerful place where change happens, behavior change happens. We poo-poo the idea of why do we tell patients to stop smoking? And yet the public health people turn around and say a GP recommending to a patient they should stop smoking is the single most powerful thing that will help people. Of course, they need to get the nicotine replacement. They then need to also get the counseling that goes with it. But that simple little action of you should do this has a huge impact on patients. Sorry, just repeat the question again. For the writing. How do I write the
The
records?
way to write records,
So
yeah.
people, yeah. So I've done presentations really from when I first started giving access to records, talking about this, and people often ask me this question around, have you changed the way you write? I always remind them and say, listen, whilst I'm at this conference presenting, there's a locum back at the surgery who's sitting there seeing the patients that I would see. Almost certainly, they have no idea that the patients can read pretty well everything that they're writing down. But we've never had a problem. In all the 16 years that we've had full access to the medical record, or 18 years we've had full access to medical records, we have not had a major problem. I've given you a few examples of where there have been issues, but we've dealt with them. So the immediate thing is that those locums are still writing how they've always written. Nothing has happened. And that would be my default answer to that question. However, I talk about records access and understanding. It's the understanding bit that's really, really important. If you notice earlier on when I was talking about HbA1cs, yes, I might be talking to a GP audience, but there may be others who are watching this or listening to this who are non-doctors who might not know what the HbA1c, and that's why I took pains in describing what normal and what abnormal is. I talk about data plus information equals knowledge. Multiple knowledge equals wisdom. Okay, and if we start thinking about a knowledge-driven healthcare system, which is where I want rather than data, it's knowledge that saves lives, it's not data. If it was just data, then I would have just said 170, and those people that know what I'm talking about with HbA1c would have known what I was talking about, and everybody else would have been blank. So if we are going to give patients access to their records, their data, we need to think a lot harder about the understanding side of things. That became very obvious to me within 2 or 3 years of me giving access to records, because patients would come back and they'd read what I've written and not really understand what it meant. And so that's why I'm going to name drop another person. Glenn Griffiths came to me and our patient participation group that went on to become the best patient participation group in the land in the UK. And you'll see that there's lots of things that have come out from access to records that have led to other people benefiting themselves. But the PPG, the patient participation group, and Glenn Griffiths in particular, helped us to build our practice-based web portal, www.htmc.co.uk. It was built from the ground up to support these patients, because whereas I might not be available 24 hours a day, 7 days a week, think about it. These are patients who are online. So the practice website is open 24 hours a day, 7 days a week. It's really obvious when you think about it like that. It becomes even more obvious when you think about the fact that patients register with your practice, not just with the NHS. And in your practice, you'll have certain people who've got an interest in a certain area, or there's a certain way of doing things. We were talking before you came online about patients needing a blood test. Well, how about putting onto your practice website the information if someone needs a blood test, how they can go about doing it? Because they're not going to find that on Wikipedia. They're not going to find that on NHS Choices.
Yeah.
They're not going to find it, but they should be able to find it on your practice website. So I started to create lots of web pages that were for specific conditions where I was directing patients to get access to their records. So I've got a page that says diabetes care, for instance. I've got a page for heart failure care. I've got a page for depression care. And again, I'll share some of these pages with you afterwards for those people that want to watch it. So now imagine you've just been diagnosed with diabetes. It's a bit of a shock. You don't quite know what it is. But if you're a patient of mine, I would then say, oh, look, you've got a smartphone there. I'm going to sign you up for access to your medical records right in the consulting room. I'm not just going to give you a piece of paper and send you out and expect you to do something else. I'll do it there. And the reason I'll do it there is because it takes me about 2 or 3 minutes to do the questionnaire. I can then process that request and send the message back to the patient, telling them how to get access to their records. But then I'll send them a link to the diabetes care page. And unlike, say, Diabetes UK's website, that doesn't assume patients are going to be able to see their test results and things, and maybe they should do that, on our webpage, we start with saying, you've now got access to your records, you should have access to your records, you should know your numbers, because Diabetes UK also says that. But actually, I want to look at your consultation, because in that consultation, I'll have written down why I think you might have got your diabetes. Perhaps you're eating too much of the wrong kind of food. Perhaps you're not exercising much. Perhaps you're from an ethnic background and you've got an increased risk of diabetes. Those are the things I'm writing down in the notes. And what I have done is I've trained myself not to write abbreviations, because they're doctor speak that only doctors understand. And it is difficult to do that. But if you do that and you write in a way that the patient can understand it, it means that they're not then coming back to you and they've got a better understanding of what's going on. So although it might be a little bit more difficult, and there may be some people on the call here who go, I don't really want to do that, you're on a continuum. You are going to think about how you can help that patient. But if you can use simple language, it doesn't mean dumb down. NHS Choice has looked into this. When they asked the public, do you want it to be called gastroenteritis or diarrhea? They said gastroenteritis. They would much rather see one version of the truth than two versions of the truth. So you don't have to dumb down what you're writing, but you don't have to write in abbreviations either. My trainees, the people that come into the practice, I try and encourage them as much as possible to write full sentences and write paragraphs and help them to understand it, so that not only can they read it then, but 1 year, 2 years down the line, when they go back, someone who's got depression, they get better. As they start to get worse again, they can go back and look at their record, just like we will look at consultations that we've had a few years ago. And suddenly, it's almost like time travel. You take you back, you remember that time when you wrote that consultation. Well, the same sort of thing happens to the patients. They can time travel back and they can remind themselves of what happened when they were in the consulting room with you, so they don't have to feel as though they have to keep coming back to see you again. So there's another example of how this could actually help to reduce the demand on GPs. I'm not going to say that it will reduce demand. It might actually stimulate demand. Remember, my patients are dying 10 years younger than the national average. That is not something I'm proud of. That means that my patients are waiting perhaps too late before they're asking for help. So it might well be that I actually want them to contact me more often. Now, that sounds crazy in the world that we're in. But you know what? I'm a GP here. I'm here to help that patient. That's what my job is. That was my calling. It wasn't to make my life. Yes, I want to make it easier. And I want to make it enjoyable. I want to make it fun. We are a practice that's expanding. I have amazing consultations with my patients. Patients walk out feeling really happy because they can read what they've written. They understand what's going on. I do a shared decision making, which means that although I'm doing 9 sessions and everyone thinks, how the hell do you work like you do? I finish work and I go home smiling, and I'm not burnt out and exhausted and tired. And it's because of these relationships. It's because of the fact that I've got this responsible sharing. It's the fact that we're working together. We're all on the same team. Those kinds of things, rather than it being a difficult relationship.
Thank you. So just as we finish off very briefly, if you had to give 3 key tips to our colleagues out there about how to basically make open access work for your patients, make it work for the practice, aside from switching it on, because that's the obvious thing, it needs to be switched on. What would those 3 tips be?
No. So the first thing, it's not to switch on. I've clearly stated that you need to go through a process. You need to be clear about what you're doing. There's that questionnaire. Remember that those people are downloading the NHS app and they say, oh, I can access the light version, not the full version, access the records. There's no check and balance in there. They could see in their problems all sorts of harmful data, third-party data that no one's ever considered about. So I do not advocate for that at all. I advocate that there should be a proper process. It's not an automatic switch on. So that's going to be the first thing. I guess in order to do that, it's educate yourself about it, but not just yourself, but your staff too. Get your PPG on board, because they will be able to see things from a patient's point of view and they can be your critical friend. I would say forget about trying to do thousands and thousands of patients, but rather just start with that one patient. There's a lovely story called the Starfish story that I just want to sort of finish with, really. And this was a guy was walking down along the beach and he saw in the distance a man with a little child. And every now and again, this child was bending over and then throwing something into the sea. As he walked up to her, he saw that this beach was full of starfish that had washed onto the shore. So he came up to her and he could see that she was bending over, picking one starfish and throwing it into the sea again. So he comes up to her and he says, little girl, why are you doing this? There are thousands and thousands of starfish here. You can't possibly make a difference. She bent over, picked up the starfish and threw it into the sea and said, I made a difference for that one. That is what I want you to think about. The patient that's in front of you. Think about how can you help them rather than thinking about the burden of thousands and thousands of people doing it. Do it slowly. Do it at a pace that you and your staff are comfortable with the resources that you have. The more resources that we have, the more funding we can get, the more we can do. That's a battle that I'm having with my LMC hat on and talking to the senior leadership in the NHS around how to do this. I know things are fluid at the moment. I know there's talk about July, but actually let's do this safe. the good news is I don't have to scream and shout. People are listening to me. The senior leadership, I had a meeting only yesterday with the senior leadership at NHS England, NHS Digital, and with the GPC leads on these things. They are listening to us. You know, let's do this right first time rather than making a mess of it and then causing all sorts of problems. My colleagues are under massive stress at the moment. I recognize that. I do not want to input any more burden on people. Yes, no one likes change. Yes, we're going to have to do a little bit more, and I've talked about these things. But let me tell you, from where I'm sitting, 18 years down the line, this is amazing. It's fantastic. I really enjoy what I do. I get a lot of pleasure out of it. Patients who are joining the practice are really enjoying it, and some of them do talk about the fact that they love the fact they've got access to their records. I can also say to you that 99% of the patients haven't done it because they thought it was a good idea. They've done it because I've actually, or the practice has encouraged them to do so. So if anyone, and the final tip really is, if you're interested and would like to know more, please get in touch with me, and I'd be very, very happy to talk to you, to provide you support. I've made videos on how to do this. The talk I give is called, I've forgotten what it's called now, No Surprises. I call it No Surprises. If you can get to a point where you, your staff, and your patients have got no surprises, how amazing would that be? It's a completely different perspective to saying, let's just switch it on and hope it's going to be okay. That is not the way to go about doing it. If we get to no surprises, it'll be really good. And then we'll all be able to enjoy things. So I'm looking forward to the next 20 years or whatever it is I'm going to continue to practice medicine. It's what I'm about. And our presence in the surgery, seeing patients, being there, it's all part of it. But the IT enables it. It doesn't replace us. Thank you.
Okay. Thank you very much, Dr. Hannon. And I know I've really enjoyed this session. And obviously, if people do have questions, feel free to go back and watch part of this. If you wanted tips on how to redact the information specifically in System 1, we've got that content for you. And that video is probably coming up right about here, right now. And as always, EGP Learning is here to help save you and your patients time by taking hands to your primary care and learning. And we'll catch you in the next episode. And check out the website down below.